everyone, and welcome to our panel today. We are so very excited to have an amazing panel of women here to talk to us about closing the gap in healthcare disparities. First, I would like to introduce you to our speaker, Dr. Michelle Wright. She is going to be the moderator for our event today. Dr. Michelle Wright is the co-founder and the board chair of the National Organization of African Americans with Cystic Fibrosis. It is a 501c3 organization with a mission to engage, educate, and raise awareness regarding cystic fibrosis in the African American community in an effort to help bring valuable resources, knowledge, empowerment to support cystic fibrosis patients, families, healthcare professionals, and the community. I also want to introduce you to Dr. Linda Goler-Blunt. She is the Vice President and the CEO of the Black Women's Health Imperative. It's the only national organization that focuses on Black women's emotional, physical, and financial health. I also want to introduce you to Dr. Jocelyn Eldridge. Dr. Eldridge was the first person in the state of Arkansas to become board certified in pediatric endocrinology. She was the 15th Surgeon General of the United States and the first African American and only the second woman to head the U.S. Public Health Service. So we are super excited to have you. And we also have Dr. Jennifer Taylor Kauser. Dr. Kauser is a professor of adult and pediatric pulmonology medicine at the National Jewish Health, where she serves as the medical director of clinical research services. So I just want to thank all of you women for being here today. And I am going to turn it over to you, Dr. Wright.
Thank you so much, Dr. Misty Resendez. We are so excited to be here today. And I also want to thank Dr. Jenny Walker, alongside the University of Arizona Global Campus Center for Women's Leadership, for this most imperative opportunity and panel discussion, Leading Change in Healthcare Inequalities, Illuminating Issues and Strategies to Empower You, your family, and your community. I am Michelle Wright, and I am ecstatic to serve as your moderator today. As the founder and the board chair of the National Organization of African Americans with Cystic Fibrosis, which is also known as NOACEF, and understanding the surreal journey of my husband, Terry Wright, a 59-year-old African-American man who spent 54 years without being diagnosed with cystic fibrosis due to perceptions based on his race and ethnicity. I can appreciate firsthand the reality of living and experiencing healthcare inequality. Thus, I am too incredibly grateful for our panel today, who exemplifies not only leadership, but change, as they all uniquely and remarkably lead change in healthcare inequalities in their own right, in addition to shining light on critical issues and transformative strategies to empower and bring about much needed change. But before we jumpstart this entire discussion on healthcare inequalities, I would like to first let our panel expound on how do they each define healthcare inequalities, and why is this discussion critical? Why does it even matter? And since Dr. Elders was so gracious enough to let me into her home and share her personal space, I'm going to start with her, but I want to give honor where honor is due. Dr. Eldridge, as Dr. Resendez mentioned, is the second woman and second person of color to ever hold the title of Surgeon General of the United States, and also the first African American woman and African American to hold this title. So she definitely has a lot of wisdom as it pertains to healthcare and healthcare equality. So Dr. Elders, how do you define healthcare inequalities, and why does this topic even matter? Why is it important?
We all know the healthcare inequalities has existed for a very long period of time, that it's a difference in health and healthcare between or among different groups. And we all know that for race, there's been a major difference in healthcare. We've been talking about eliminating disparities ever since we've been talking about healthcare. And we've been talking about what we're going to do about it. But it has not only to do with race, but it's related to our culture, it's related to our environment, our education, our economics, all of those things, and all of those other social determinants. It's more than just the health, the doctrine as we may define it, but all of those other things are important and critical in healthcare.
So well said, so well said. And thank you for that, Dr. Elders. Linda, would you like to elaborate on your definition of healthcare inequalities, and why do you believe it's important to even have this discussion?
Well, thank you so much, Michelle and Dr. Elders. It's just a pleasure to be in the same space with you. I'm having trouble. I can't actually turn my video on. It says the host has stopped it, but that's fine. I want to dive right in because this conversation couldn't be more important and more timely. So I just want to thank you so much for convening these thought leaders. And so I would have to say I agree with everything Dr. Elders has said, and she has seen it and lived it, researched it, been in practice, so she knows this issue from all angles. The one thing I would say is when we talk about inequalities, we're really talking about justice. We're talking about differences that shouldn't exist. If we all had access to the things we needed to do to be as healthy as possible, then whatever differences in our health outcomes would exist, we could actually call that health equity, because equity doesn't mean we all are the same. It just means there are no barriers. It's not money, it's not insurance, it's not the location, geography, it's not attitudes that keep us from having access to quality care. If those things didn't exist and we all had access, then we could say inequalities in the access in healthcare didn't exist, and whatever our health looked like, that would be the state of health, and we could call that equity. But the problem is we don't all have access. Maybe it's geography, maybe it's from the moment you walk into your provider's office and how the front office staff treats you. But the thing we do know is that we have invested over $200 billion in this issue since the Heckler report that I know Dr. Elders will remember. And in many respects, those differences, those inequalities are greater now than they were in 1985. So I agree, we don't need more research. We don't need to study this more. We've described it, we've named it. We need to take action, and we need to demonstrate what has to be done in the provider's office, in the hospital, in the halls of Congress, in training our healthcare professionals to actually eliminate those inequalities and make sure every person, obviously I'm focused on Black women, but every person knows that they're valued and respected and will receive high quality care when they walk in the door, from the moment they're there to the last day of the last treatment.
So well said. And we do apologize for the hiccup with the camera, and I do believe you are able to turn on your video now. But thank you for those words of wisdom. And Dr. Taylor-Kowser, would you add your perspectives as well?
Yes, I'm just going to echo first what has been said. Thank you so much, Dr. Wright, to the organizers. It is an honor to be on this panel today, and it's so important, and it's a life or death topic, and that's why we're here. So it's already really been well said what health inequity is, but I'll just add that there was a discussion at the World Health Organization back in 1992 that was summarized, and they defined health inequity as something that Linda already touched on, but health differences that are avoidable, unnecessary, unfair, and unjust. And we need to change those factors. It is important because, again, it's life or death. The pandemic has highlighted how much inequity exists in the healthcare system. People are suffering and people are dying because of inequity in healthcare. The lifespan of people in color was already lower in the US before the pandemic, and that gap has widened. So it is time, as Linda said, for us to take action.
And action is so important. I concur on all fronts. Thank you so much. Your perspective is so valued. This brings me back to you, Linda. I've had the opportunity to serve with you on a healthcare disparities and rare disease panel last year, actually around the same time. And with you being the phenomenal president and CEO of the Black Women's Health Imperative, you and your BWHI team have been able to effectively target some of the most pressing health issues affecting Black women and Black girls in the United States. So can you elaborate more on your mission and some of the most pressing issues and related strategies, programs, and advocacy outreach that BWHI has effectively identified and tackled?
Well, thank you. So, Dr. Wright, you are my partner. You are my partner in crime as we address these inequities and the injustices in health. So I couldn't be prouder to have been able to start this journey with you. As you said, this is year 39 that the Black Women's Health Imperative has been in this fight for health equity, for improved health outcomes, for changing the narrative around Black women's health from one of a deficit to asset. We in public health talk often about how Black women die 42% more from breast cancer or have 3 times the cervical cancer mortality rates. And the problem is we often lead people to think, well, what's wrong with Black women? And there's nothing wrong with Black women. It's these inequities that Dr. Eldridge has talked about. So what we did about 8 years ago when I started was we asked Black women to define health. And it was a purely qualitative study. We just said, give us words and phrases. What does health mean to you? Turns out that about 80 to 85% of the words and phrases Black women used to define health were psychosocial. I'm calm, I'm at peace, I'm in control. About 10% were financial. I can keep a roof over my head, I can take care of my children. Only about 5% of the words and phrases Black women used to define health had anything to do with physical health or disease state. So what that said to me and all of us was that Black women don't view themselves as the sum of body parts that go wrong. They view themselves as having agency, as having intelligence, as having the ability to make good decisions. The issue is what they have access to. So we've taken that approach through our diabetes prevention work. We're a grantee of the Centers for Disease Control and their top performing grantee for diabetes prevention. They've asked us to create curriculum specifically for Black women, Black men, Latinos, and the indigenous population. We were in the fight when the U.S. Preventive Services Task Force wanted to raise the age of screening mammography from 40 to 50. Well, if that had happened, 2 things would have happened. 1, insurance companies would have stopped paying for mammograms under the age of 50. And another 1,200 to 1,300 Black women would have died each year from breast cancer. We were in 30 meetings, and in most of those meetings, I was the only Black person in the room. And you mentioned the Rare Disease Diversity Coalition, the first of its kind to finally look at what we need in clinical trials participation, in pipeline development, in funding, and in the creation of evidence. Because I know Dr. Wright, better than anybody, what becomes evidence depends on who's asking the questions, who they're asking, who's analyzing the data, and frankly, who's funding it. So our focus is very much on what changes in behavior and systems have to occur so that we hopefully in 10, 15 years from now are not having the same conversation about inequities and disparities in health outcomes for Black and Brown people.
All I can say is thank God for the Black women health imperative. Woo, the power of BWHI voice. Just so grateful for you. Thank you so much, Linda. And you are phenomenal. Dr. Telekauser, would you like to add your take as well?
Yes, thank you, Linda. I completely agree with you about the narrative. We really, to achieve health equity, have to acknowledge the multi-layered systemic barriers that lead to poor health outcomes, and we really have to dismantle them. The Western Justice Center actually talked about the 4 I's of oppression: ideological, so at the societal level; institutional, our government institutions, our schools, our hospitals; interpersonal, how we're behaving with each other; and internalize, what we start to believe because of all the bias that exists, what we believe about ourselves. So all of that needs to change, but I really do want to get to your point about the health narrative. So I really think the most pressing issue is changing that narrative, because as you said, the narrative has been that the reason Black people have health outcomes that are poor is because there's something inherently wrong with Black people. So they aren't looking at the root cause of why, for example, people with Black people have more asthma rates. They have more asthma rates because there's been redlining and predatory lending practices that have caused many Black people to live in neighborhoods where they're exposed to higher levels of pollution, and higher levels of pollution cause lung disease. So we have to change that narrative about what the cause is so that we can actually make laws and policies that address the root causes. Changing laws and changing policy does make some difference, but if we don't change the narratives, we're going to continue to have problems like we had with Terry Wright. So the laws had changed. There was no longer segregation in hospitals, no longer segregation in medical schools, and Medicare and Medicaid were put in place. And even the ACA was put in place. But nonetheless, in spite of all those things, because the narrative was that only white people get cystic fibrosis, Terry was misdiagnosed and suffered over and over again for long, long periods of time because that narrative hadn't been changed. So we must change the narrative. It is not a problem with Black people. It is a problem with all of those layers of the barriers that prevent people from being able to be healthy.
So well said. Thank you. And Dr. Eldridge, we have to add your perspective to the table.
Well, yeah, I think all the things you've said are true. And it's because of the hard work that you've done. I remember years ago, I don't even like to talk about how many years ago, when Black women's health imperative, nobody was even talking about Black women except, we go, we talk about, they even thought, like the reason why our infant mortality rate was so high. They said it related to education and the fact that Black women just didn't know how to eat and exercise, all the things that were said. And then they really did a very carefully controlled study using same age, same college educated Black women and compared to even young white girls. And they found there really was, because of all the other things that was going on, that there really was something different about Black women, that they really more likely to have premature babies. And the reason why our infant mortality was so high was related to the fact that the babies were born premature. So, but when you really look at all of the stresses that Black women have had to carry on for so many years and the things, so I really think that now that we're beginning to put some of these things on the table, and we're beginning to make it known. And we are beginning to look at the fact that the finding out that the breast cancer they have is a far more malignant kind of breast cancer. So there are just all kinds of factors that are coming out. And I think as long as we keep pushing out, putting forward and saying, let's look at all of these factors and not just say, well, it's just because they don't do what the doctor says, all the things we say. So I feel we've got lots of work to do and we must keep on working.
Thank you, Dr. Eldridge, and thank you for all the work you have done. It's just an honor to be sitting here with you.
It's just a pleasure to be here with all you bright young women that's changing the world. I'm so proud.
Thank you. Thank you so much. So Dr. Taylor Kauser, that brings me to you. You have been an absolute invaluable resource and mountain of support for cystic fibrosis patients in general, and for my husband, Terry, and me, and our National Organization of African Americans with Cystic Fibrosis Foundation organization in particular. And not only have we been privy to have you as one of our inaugural speakers for our annual Blacks, Indigenous, and other minority ethnicities with rare and genetic disease conference, also known as BioMerge Conference, which is actually scheduled to take place on February the 26th of this year. But you have helped us to develop the Wright Cystic Fibrosis Screening Tool, which is available in English and Spanish, and for patients and providers to help people self-identify symptoms that could be related to cystic fibrosis, and to help medical providers identify people who may have CF, especially individuals from the BIPOC community, being Blacks, Indigenous, and people of color. So in your numerous roles at National Jewish Health, and I'm just going to name a few: Professor, Departments of Medicine and Pediatrics, the co-director and CFTDN director, CF program, medical director, clinical research services, president-elect medical staff, and interim associate vice president of diversity, inclusion, and equity. You have probably seen health equity at not only its worst, but its best. So can you elaborate on how you have personally and professionally targeted health equity and the path that you have seen it take for better and or for worse?
Thank you so much for that really kind introduction, Dr. Wright. And it has been fantastic to partner with you to try to change, again, the narrative about who is affected by CF. And Dr. Eldridge, none of us would be here without the work that you did. So thank you so much for blazing this trail so that Linda and Dr. Wright and I could be here. So I mentioned earlier that the dominant narrative causes harm. So a concrete example that I'm going to expound on a little bit is, again, in cystic fibrosis. So back in 1938, when Dr. Dorothy Anderson described cystic fibrosis as a disease, in her seminal paper, she said that there was a child who was Black and a child who was Hispanic in that paper. But for 80 years, it has been couched as a disease that only occurs in white people. And that has caused harm. It caused harm to Terry Wright. It has caused harm to numerous people of color who have been late diagnosed and misdiagnosed. And again, you think, oh, well, it's because of race. Well, it is because of race, but that is because, for example, newborn screening, which is done in every state in the US, it's done differently in every state. And in some states, there are mutations that are missed because they are predominantly in people who have different genetic ancestry than those of white people. So because of who is making the laws, they missed the people who should have been included in those tests. Also, people at every level of their medical training have been taught that cystic fibrosis only occurs in white people. So if someone like Terry walks into their office, they automatically assume that he can't have the disease because he is Black. And that is because of the way we have done our medical training. We have done it incorrectly because of these incorrect narratives. So we really have to change these narratives that are harming people. Another example is the fact that when all these great therapies that have been developed in cystic fibrosis were developed, they were developed with mutations in mind that occur in people of European ancestry, not in people of Black, Indigenous, people of color ancestry. And therefore, there are more likely going to be instances where they don't qualify for these medications because their mutations in the CFTR gene were not considered when these drugs were being developed. So we absolutely have to change the narrative. Now, obviously, I have the privilege of sitting at a lot of tables, and so I'm trying to use my voice to change the narratives within my sphere of influence at my institution, within organizations that take care of people with respiratory disease like the Cystic Fibrosis Foundation, American Thoracic Society, your organization, Michelle. So changing the awareness of the fact that people can be affected who have CF, who are people of color. I mean, obviously, I've also had the opportunity to partner with you on the screening tool. Again, we need to change how we talk about these issues at every single level, at the institutional level, within society, interpersonal. But we also need to empower people to help themselves. And that's exactly what the Wright tool is intended to do. So it's going to take us a while to change all the medical school curriculum, to change the curriculum in nursing school for respiratory therapists. But what we can do right now is tell people, look, if you have these symptoms, take this symptom screen to your doctor and tell them that you need to have a sweat test done so you can be diagnosed with CF. We need to find more ways to empower people to help themselves while we continue to work on all the barriers that exist to them getting equitable health care.
Thank you so much. I can tell you, you have been a priceless asset to Know Self and to our initiatives. And I cannot thank you enough for coming to the table for us from day one. And so I can speak on behalf of Terry, myself, and Know Self, and just tell you thank you for all you are and do, because you are helping to get this conversation not only started, but continuing, and your voice is irreplaceable. So thank you for all you do.
You're welcome, and you too, Michelle. And I didn't answer the second part of your question about the worst part of what I've seen with inequity, and I think we all can relate to the fact that there is some risk and some cost to trying to change the narrative as we're doing. And we've seen this recently, all of the book bannings that are happening across the country, those books that are trying to help change the narratives, the bomb threats that have happened against historically Black colleges and university, and probably most recently, the white protesters and nationalists who are protesting attempts at health equity at Brigham and Young. So there are efforts, as there have always been, every time in history that we've tried to change the narrative, there have been people who are trying to close the voices and close the doors. We have to keep resisting that. And everyone on this panel knows that, and everyone's doing it. So again, thank you, Dr. Wright.
You are so welcome. And I would like your perspectives on that too. I'm sure you've seen at its worst and the best.
Well, of course, we all know, we've seen, this example with cystic fibrosis. And I remember, we were in Arkansas, we were diagnosing Black people occasionally with cystic fibrosis, back in the 60s, only because of probably bright, pushy people. I say pushy people, but demanding, if you don't demand that things get done, they won't get done. If you don't say anything, when you get to where everything is done and you don't have anything to say, as my brother always says, he says, when you get where you don't have any complaints and and you got everything you want, you need to be at the graveyard. So I'm saying that we need to make sure that we're always out there really pushing to get things changed. The day we see the truth and cease to speak is the day we begin to die. So that's why we need to be at the graveyard. So I'm just really pleased that all of the things that this group is doing and all of the things you've done I'm just very proud of the Black Women's Health Imperative. They were just out there years ago. I remember when I was going and speaking to their groups and all, that they were out there really talking, and Black women were dying with breast cancer and early breast cancer, and somehow they were just saying, well, things didn't work as well on Black women. And before they really found out that they really had a different genetic disease, and it was a different, and we were treating them. I realized that we may have gotten to diagnosis a little bit late, but that was because we didn't have the same quality health screening. So, and we didn't know, so we could get there early. So I'm very pleased with all the things that are being done and that are really making a real difference. I'm so pleased that we improved and began to make a real difference. You know, teenage pregnancy was just such a problem. Children becoming parents before they became adults. And nobody wanted to talk about that. And nobody wanted to tell the children anything. They didn't want to educate them. They went around, if we tell them about it, they'll do it. Well, heaven forbid. When you have the highest teenage pregnancy in the industrialized world, that says they're already doing it. What you need to do, we're sexual beings from the day we're born until the day we die. We need to teach our young people on how to be sexually healthy. And just saying don't do it won't get it. We want to teach them how to take care of their sexual health. And to me, that's what I feel. And I feel we have a real responsibility to keep doing it. We've got to always, and that's what I feel that this group is doing, we've got to always be sending the ladder back down for the rest. We can go and pat ourselves on the back and say, well, we got out. But it's those who may not have been able to be as fortunate. And so I'm saying that we have to make sure that we have climbed the ladder of success, but we have to make sure we send the ladder back down for the rest. And for that, I'm very grateful that there have been just starting the Joycelyn Elders School of Allied Health Professions and Public Health to train young people in public health and health education, and to train community health workers. Because sometimes a good community health worker can do more saving in improving health than the neurosurgeon.
That is phenomenal. When I grow up, I want a school named after me.
Oh.
Linda, we have to get you in on this discussion. Please add your perspectives as well.
So I'm going to start with Dr. Taylor Kauser going to every single medical school. You're just going to take a sabbatical and have this conversation with every medical school class there is. Because we need all students. And then you need to talk to all the physicians. It is interesting, I find, you talk about health equity at its worst. In my opinion, it's when I hear people say, oh, it's such a big topic, we just don't know where to begin. And to me, that's code for we're not going to do anything because we really don't want to. Because to really deal with health equity, as Dr. Taylor Kauser said, you can't separate it from the social policies. I mean, health policy is social policy, is financial policy, is economic policy. You can't tease these things apart. So, redlining and maternal mortality. Well, red line districts are 13 degrees warmer in the summertime than non-red line districts, and we see higher rates of maternal mortality. I mean, we could just go on and on. So at its worst is when it becomes this reason for doing nothing because it's just too big. Many of us in the medical field and in public health talk about social determinants of health. That's the thing we always go back to. But very few people stop and say, well, I wonder why the social determinants of health exist. That's where we have to begin. So we go back to hundreds of years of oppression, 400 years. Let's start with racism as the social determinant of health, gender discrimination. If we want to really deal with health equity and eliminating inequalities, then let's deal with racism and gender discrimination. And we have research actually that supports that. I mean, you look at Arlene Geronimus talking about weathering and the allostatic load in Black women, Tanae Lewis, who found a causal relationship between experiences of racial discrimination and changes at the DNA level. The Black Women's Health Study. I mean, there have been so many where we know our bodies, Black women's bodies, Black people's bodies literally are responding to this toxic stress, the epigenetic expression of stress, year after year after year, generation after generation. And yet we get blamed for diabetes, for heart disease, for hypertension. And when we are seeking care for a disease that we can't figure out, Terry walking into the office, others walk into the office with symptoms, it doesn't occur to providers to say, maybe I should do a sweat test. Maybe I should do this. Instead, they say, well, what have you been doing? As if it's Terry doing something. We have another, colleague that, Michelle talked about trying to get his kidney disease diagnosed. Well, the doctor said, you need to stop eating all those fried foods. This guy was a vegetarian. He's a vegan. It's like, I don't eat this stuff. But it doesn't occur to our providers to just stop and consider these people as people. And that is, fundamentally rooted in racism. We talk about unconscious bias. I don't know, Dr. Taylor-Cousar, if you believe in unconscious bias. I can't say that I do, because it has been ingrained in our healthcare system. And I'll just end with, I want to see there's good work happening, but if you just go back a year and a half ago, COVID-19, there's all this, the discussion about disparities, but then pulse oximeters turned out didn't work as well on people with dark skin. Dexamethasone didn't work as well as in African Americans. Well, neither the device nor the drug had been tested among Black people or people with dark skin. So it was not a surprise. So until we actually look at the whole of health and what drives therapeutic development and medical devices, our research, and make that truly inclusive, not from just the patient perspective, but the people making the very decisions about the research and what's funded. Cystic fibrosis is another one of these where you compare cystic fibrosis to sickle cell disease. Cystic fibrosis has fewer patients. Every one of them is important. It's got 7 times the funding as sickle cell disease. And still, after all we know, when a Terry Wright walks into the office, doctors don't think, maybe it's cystic fibrosis. So we have got to change how providers think and look and act. And until we do that, that's why Dr. Taylor-Cousar has got to get on the road and start talking to all of these people.
Linda, I am trying. Zoom is making it easier. I'm speaking at another medical school next week.
Good.
Good.
But I completely agree with you, Linda. And we have to change it at the medical training level. There's this, I don't know if you've seen it, but Chidebere Ibe is a Nigerian medical student who has been studying, and he looked at his textbook and he's like, why are there no pictures of Black people in my medical textbook? There are such a paucity of illustrations of people of color in medical textbook. And he is doing his part to try to change that. Unfortunately, that's working, and people have seen these images, and what we need to see now is them being incorporated into every single medical textbook. Whether, again, you're training at the nursing level, you're training at the medical school level, respiratory therapists, physical therapists, every single person in healthcare needs to be trained to think about everyone in medicine and not just look at the white images they see, rely on those dominant narratives that they've been told their entire life. And we need, like you said, Linda, to change how people are approached. I've said before, I'll walk into a doctor's office and I'll say up front that I'm a physician, which I feel is really obnoxious, but I'm doing it because I've seen what's happened to family members and friends who walk in and assumptions are made about why their disease exists, and it's based on race. So we really have to start at the medical school and the medical training level to change these narratives and change how people view disease.
You are so right. And I'll just say, sometimes knowing what we know can make us crazy. Right now, my daughter's in labor. It's a wonderful thing, except what I'm thinking. And, we talk about knowing your numbers. It's like, I got the number to the chair of the board. I got the number to the president of the hospital. I've got the number to the editor of the newspaper. Don't make me, because she's a well-educated woman, but we know Black well-educated women have higher maternal mortality rates than white women without an 8th grade education. So I want everything to be wonderful and rainbows and glitter, but I am prepared to have to be that woman in the hospital if need be. I shouldn't have to worry about what kind of care. She's at a phenomenal institution. I think she's getting phenomenal care. But, she also has access that a lot don't have. So when I'm talking to Black women, I'm telling them, you've got to be prepared in case things go south so that you can protect the lives of your loved ones. We shouldn't have to be on guard in that way. We should just be able to know that they're going to get high quality care and everything's going to be fine. I'm very fortunate. We've got to make sure that same access, that same ability to not have to be stressed and worried about something like this applies to everyone.
Yes.
And until we get that kind of high quality care, we can never get rid of disparities.
No.
We've got to have high, I think healthcare should be a human right. It should be a right for everybody. But, we need high quality care, whether they're in rural or urban, rich, poor, regardless. And until we can get that, we cannot eliminate our.
That's right.
We can't talk about equity.
That's right.
I think one of the things that this virus has taught us, it's exposed our vision, and we now all can have 20/20 vision. But now that it's opened our eyes, uncovered it, and showed us, exposed our weak underbelly for what we really are, hopefully we can use it to correct some of the real disparities that we've been talking about ever since I've been doctor.
Thank you. So well said. Everyone. And what's interesting, we are all aware, not only is health advocacy important in leading the change in healthcare inequalities, but so is self-advocacy. Therefore, it is important for those seeking health services to know what to look for in identifying with health inequality or health equality, as well as look for ways to overcome. But oftentimes, as we all know, people who suffer these inequalities may not even recognize that they are being underserved. So, Dr. Eldridge, what are actually some signs of healthcare inequality in action?
Well, I think some of the real signs, it goes on both sides of the street. We've got to have more people that look like us. Mm-hmm. Until we began to get more doctors, nurses, or healthcare professionals that are Black, brown, or whatever. And we've got to have, and we've got to make those healthcare that are out there culturally competent.
Yes.
That many of them are just not culturally competent. They don't, they don't ask the right questions, and they just really don't have any appreciation of the problems that we face and what goes on. And we've got to make sure that we educate more of our doctors and our healthcare professionals about the social determinants of health. You know, I think we will walk around and think, well, the only thing we need is the doctor. Well, you know, I think that they've shown over and over again, only 10% of our health is really related doctoring. The doctoring, much is related to the environment, our nutrition, our exercise, things we can do for ourselves, things our people can do for our communities, and our mental health. You know, we often get all involved in physical health, and we look around, and it's our mental health that's just wiping out a large part of our communities, our schools, our churches, everywhere. So I think that we've got to make sure that we begin to pay some attention to those. And the other thing, we need to look at the location of some of our healthcare communities. Many times they're miles away from anything near the the poor communities. There are no grocery stores that carry vegetables. You know, there's a liquor store on every corner, but they don't have grocery stores that carry fresh vegetables. So these are some of the things that I think that we need to do and we need to fight about to try and improve.
So well said. Thank you, Dr. Eldridge. And Linda, can you shed light on what customers of health services can do to be aware and proactive in getting their needs met in the face of these inequalities?
I would say, you know, first, and what we say to Black women is look around you, look at what's happening, look at your neighborhood. You know, what's happening in your neighborhood. Look at your school system. Is it high quality? Does your school system lack sort of the basic resources in comparison with other systems? Look at your job. What's the diversity looking like? What's the promotion pattern looking like? What are the wages in comparison? And then we really start with, how do you feel? Because we really, like, how does it feel to be a Black woman in this society in this moment? And really kind of tap into that and know two things. One, solving inequities in healthcare is not our responsibility. It is not the everyday Black woman's job to do that. But two, to tap into her network. So when you're talking just sort of the basics, as I say, we know how we feel when we walk in the office and the front office staff kind of looks at us like, what are you doing here? I mean, already it sets up something that's not positive for our healthcare. But because we can't always count on getting high quality care, we bring someone with you who can be your eyes and ears, because it's our health. We get caught up in trying to just do the basics of understanding that we may miss some of these cues. Then go have that conversation after with your friend. Like, okay, what just happened? Explain so that you know what kinds of notes to take. And then the thing that's really important, particularly just with healthcare delivery, because as Dr. Eldridge said, so much of our healthcare has nothing to do with healthcare delivery, most of it, in fact. But when it comes to that, when you go back to that provider, then you can say, okay, you did this, I saw this, here's what I want. And know that you can demand and you have a right to get a certain level of care, to get certain things, but you've got to know what to ask for. So sometimes it takes somebody else with you listening so that you can make that list and go back and make sure that you get what you should get.
I like the health buddy system. I like that. And Dr. Taylor-Counselor, how do we overcome obstacles in real time in an effort to prevent healthcare inequality from happening in the future?
Yes, I'm going to agree both with Dr. Elders and with Linda about what they said. With Linda, one of the points on my list was take a buddy with you. Take somebody you know, somebody you trust, so that they can pick up on those things that you might miss. And if they see bias, it might be easier for them to see it, and it may be easier for them to speak up because they don't have that same relationship with that physician. So they can point it out without feeling so vulnerable as you might feel. And also, as Linda said, know your rights. I mean, it's easy for me and my privilege of being in the healthcare field and knowing what patients' rights are, but you need to know your rights. In the past, people went to the doctor and what the doctor said was what you listened to, you did that, you didn't ask any questions. It is perfectly acceptable and reasonable for you to ask questions of your doctor. Why are you prescribing me that? Why do you think that? Your doctor should be your partner in your health, not your dictator in your health. So work with your doctor as a partner and don't just listen to everything they say. They have a lot of good advice, but question it when you need to. And to Dr. Elder's point, we don't have enough of us that look like us in medicine. I mean, the number in medical school of Black, Indigenous, people of color, that has continued to go up. But if you look at the faculty level, it's changed very little in the last 20 years. We are underrepresented in the healthcare field. And that is because of the culture of medicine at the institutions, the minority taxes that happen. People are told they have to work twice as hard, and it's true that we need to make that stop happening. We are taken or given the responsibility of, as Linda said, dealing with all the healthcare inequity. It can't just be put on the plate of the few Black, Indigenous, and people of color who are in medicine right now. We need allies, we need partners that are helping us make those changes. And we need to change the culture so that I am not the only Black doctor in the entire room or in the entire department, or Linda is not the only Black woman sitting at that CEO table. We need to change that because that is going to make a difference in real time.
So well said. And a final question as we prepare to take questions from our wonderful viewers. What is the biggest change you would like to see in health equity in 2022 as it pertains to change for the better? As for me, it is for health equity to become the norm and not the unique exception. So how about you, Linda? What is the biggest change you would like to see in 2022?
Well, I want to see behavior change across the board, whether it's at the corporate level, philanthropic level, public sector, certainly at the practice level. But if I could make a change in the delivery of care, I want every single provider to treat every patient as though he or she was their most favorite relative on the planet. And whatever they would do for that person, for that favorite relative, do for that person, that patient. If we do that, at least in that space, we've got the best quality care, we've got equity.
I love that. And how about you, Dr. Telekauser?
Well, I'd say since the widely publicized murder of George Floyd, institutions have been more willing to have conversations. But as Linda has said repeatedly, we need to actually put some money and some investment into making changes. So I want institutions to stop just talking about it. I want them to invest real money and person power into changing the narratives, change how medical school curriculum is taught, change the microaggressions and the bias that their providers have by training them. We really need to start putting money and person power into making the changes that are going to make it possible for Linda's dream of people walking into their office and being treated like the favorite family member. We have to make those changes.
Absolutely. And Dr. Eldridge, what is the biggest change that you would like to see as it pertains in health equity in 2020 and for a change for the better?
Certainly everything that's been said already, I agree and support that. But one of the changes that I really want change, I really want healthcare for everybody to be a human right. We're the richest country in the world. We have 5% of the people, and we have 25% of the wealth of the world. And there are hundreds of other countries that have offered healthcare for all of their people. And we still have a large percentage of their people who can't get healthcare. And if you don't have health insurance and know that you can get care, well, then you're less likely to go. We know the people who do not have health insurance is less likely to go in for preventive healthcare services. And I want us to really improve our public health. We've got the best sick care system in the world. The problem is we don't have a healthcare system. We do not. All we have to do is look at where our crime rate. And so I really, really want us to improve and have better health care for all of our people. And one of the ways we can have it is to really make sure that we have offer health services as a right for everybody. And then the other thing is I feel we need to get our schools and education and everybody involved, because we need to have better health education. You can't keep ignorant people healthy. So we've got to educate our people so that they can be healthier. We can do more to improve our own health than all the doctoring in the world. Exercise, there are just certain good nutrition, maintain our body weight, eat right, and not engage in behavioral like drinking, smoking, shooting, suicide, homicide. There are just things that we can do to improve our own health. And I think we've got to get involved. I'd like us all to be better educated so we can become better involved in our own health.
So well said. And that's one of the reasons Dr. Jennifer Taylor-Cowser, in coordination with NOAA created the Wright Cystic Fibrosis Screening Tool to help people not only have their own self-advocacy, but be able to potentially say, hey, I know I'm Black, but I can still have cystic fibrosis, and this does not belong to any particular race or ethnicity. So, well, I know we can go on and on and on, but I'm confident that our audience has their own set of questions for this phenomenal panel of leaders and health experts. So let's try to take as many as we can in the remaining time. But before I turn it back over to Dr. Resendez, I will wholeheartedly like to thank this esteemed panel again, Dr. Jocelyn Elders, Linda Gola-Blunt, and Dr. Jennifer Taylor-Cowser, alongside the University of Arizona, the Center for Women Leadership, again, Dr. Jeannie Walker, and the Ford School of Business and Technology for this most insightful opportunity. And much love and appreciation to each of you who took your own precious time to listen and participate in today's most engaging and instrumental discussion, so that we know that the best is still yet to come in life and in health equity. So I turn it back over to you, Dr. Resendez, and we look forward to taking as many questions from our viewers as possible.
Great. Thank you so much. This was such a informative panel. So I appreciate all the information you shared with us today. Just because we're right on the hour, I just want to be respectful of everyone's time. What if you can just give us a resource, a website, a book, a tool that our viewers can go to watch, right? If they want to be advocates in the healthcare disparities and closing that gap. You mentioned so much about self-empowerment. Like, is there like a website or a checklist that they can have so they can know if they are being not treated fair? What would be their next step if they're not getting that high quality care that you referred to? So just some resources that maybe we can provide.
Yes, absolutely. I would start with the National Organization of African Americans with Cystic Fibrosis. That is abbreviated NOAACF.org. You can follow us on all the different websites, on social media, but we also have the Black Women's Health Imperative on here. And I want to make sure that Linda shares their website. Want to make sure, I think I know it, but I want to make sure we get that right, and want to see if Dr. Elders or Dr. Jennifer Telekauser have a website or resources as well. And please make sure when you go to knowitself.org, make sure you check out the Wright Cystic Fibrosis Screening Tool. We are making a difference and we are helping to save lives.
Well, thank you. Our website is bwhi.org.
I would have had it right.
Yeah, and you could try also rarediseasediversity.org to learn about what is happening, and you will see words from Michelle on rare disease for patients of color. And there's also a Black Health Bill of Rights that the Council on Black Health put out. It's COUNCILBH, councilbh.org. So download the Bill of Rights so you can also, to Dr. Telekauser's point, understand what your rights are when you're engaging with the healthcare system. Thank you.
That is so important. Thank you. And I know Dr. Jennifer Telekauser mentioned, of course, the Cystic Fibrosis Foundation, which is cff.org. Dr. Jennifer Telekauser, any other resources you would like to share?
You can definitely go to the National Jewish Health website, where we talk about how you can look for signs and symptoms of multiple respiratory diseases, mostly because we're a respiratory hospital. We have information about those different diseases on our website. I also put in the chat a discussion from the AMA, which historically excluded Black physicians from its ranks for many, many years, but changed that and now is trying to remedy that and make up for it. They have an actual equity health guide that has some incredibly important information in it.
Great. I thank you all so much for that. We were putting them in the chat as they are coming across. We will also follow up with our participants in an email so they can have access to these resources again at a later time. I just want to thank each and every one of you for attending our events and just sharing all of your knowledge and being women leaders in this time of change. We definitely need more women of color in leadership positions. So thank you all so much. Just quickly, I want to talk about our upcoming events that we have at the CWL. We have on February 18th from 1 to 2 p.m. Mountain Time. We have Women in the Workforce Post-Pandemic, where we are going to be talking about the challenges and the present success strategies that we can use. In addition, we also have a community chat that's coming up on February the 24th from 4:30 to 5:30 p.m. Mountain Time, where we are going to talk about living in the possibility, staying positive while balancing work and life possibilities. So again, thank everyone for attending. We put the registration link in our chat. It is free to attend any of our sessions, so please share the link. Visit us at our websites. Thank you all so much for attending.